Hi everyone, my name is Jhb Musa. I'm a family physician in Joburg, and this is the CPD meeting of the Johannesburg Health District. Great to have all of you here. We're very pleased to be able to have Lynne Wilkinson and Navlika Ratanji. Lynne Wilkinson will talk us through the plan that we have as a revised plan for the Johannesburg Health District, a plan that we think quite useful. We'll wait, I think the number of participants are growing, so we'll give it a few seconds before we start, and I'll just repeat a few things. And this is one of the challenges, is to start and coordinate all this. Okay, it seems to have settled at about 25 participants. Thank you all very much. We can proceed. So once again, my name is Jhb Musa. I'm a family physician that is in Johannesburg, also the Wonga Africa president. This is the CPD meeting of the Johannesburg Health District in the Department of Family Medicine there. And we're very privileged in having Lynne Wilkinson, who is a infectious disease specialist, who's had lots of experience. She's a public health practitioner, but very much involved in infectious disease and also the Infectious Disease Society in Southern Africa. And she's going to talk about a plan that she has worked with us in Johannesburg to try and refine an original plan that dealt with the COVID. This comes with the expertise and insights that she has as a public health practitioner interested in infectious diseases, having worked in Sierra Leone on Ebola. And I think that that sort of scrutiny has really made a big difference to the plan, in that we are really a lot more diligent about some of the infection control issues. So without much ado, I'd like to hand over to Lynne and ask her to share her insights and what we're doing. It's a plan that is a team-based plan. So thank you, Lynne. Over to you.
Hi, good afternoon, everybody. I'm just going to move over to sharing my screen. And then...
So I just stopped mine.
Sorry, now I can only see myself, which is not that useful. Sorry, just hang on a moment.
Share screen at the bottom, yeah.
Share screen. There we go. Can everybody see the screen? Well, I hope so. Put up your hand if you're having a problem, but hopefully you can see my screen nicely now. Shabir, you can see it? Perfect. Okay.
Thank you.
So, no problem. So this afternoon, I'm going to take you through a slide deck that essentially explains how to set up, very practically, how to set up a facility during the COVID epidemic to make sure that we protect our patients and ourselves. It's a little bit long, but hopefully it really gives you, using lots of photographs, an idea of how to set up each different type of facility. Okay, so why are we preparing our facilities? Number one, we want to protect our patients from coronavirus infection when they actually attend our facilities. Number two, and probably equally importantly, we want to protect our healthcare worker staff from contracting coronavirus during the pandemic. Number three, we want to set up our services so that we're able to continue to provide health services during the epidemic. And many of us are strongly of the view that we're not in for the short term here. We need to be able to create sustainable setup at our facilities that can be managed over the next 9 to 18, potentially even 24 months. And so any sort of service where we're having to close services down or prevent patients from seeking health services are not sustainable in the long term. And then lastly, that we make sure that we're appropriately managing our patients with COVID-19 or with COVID-19 symptoms, with testing, referral, and appropriate management. Now, where we started a few weeks back, and I'm using a lot of photographs from the intervention that we've implemented in 6 and now even closer to 11 of the community health centers and some of the district hospitals in Johannesburg. Many facilities, when we visited them, had already started trying to set up IPC. This is a picture from one of the facilities that I've been working at. When I arrived at the facility, they'd already set up a sanitation station. They'd externalized their chronic management, so all their chronic treatment refills were being done from an outside gazebo. And they tried to reduce non-essential service attendance. But what we still observed was very crowded entrance and queuing, so no social distancing outside of the facility. The sanitation station at the gate, and because it's at the gate with a security guard providing the sanitation, a lot of clogging and pushing from patients. All the primary healthcare chronic patients were waiting outside the premises, not inside the premises, with the community health workers triaging, going inside to the external tent to fetch the file, fetch the script, and bring the treatment outside of the facility premises to the patient. We saw some services at that time, although this has changed, such as EPI and some acute patients being refused entry and being sent home. And I think most worryingly, we saw very anxious and stressed healthcare workers. We hope that by the end of this presentation, we can show how we've managed to change this around quite quickly. So really, for whatever facility we're setting up, we need to set up what we call 3 zones. And we'll talk about these zones. We call them the yellow zone, the orange zone, and the blue zone. The yellow zone is the moderate risk zone. So this is really the zone where we haven't been able to yet separate out patients with symptoms and without symptoms. Our orange zones are our high risk area, because all of the patients in our orange zone are COVID symptomatic. And our blue zones are the areas where we only have patients that do not have COVID symptoms, but we also know they can be asymptomatic. And so that means we still have to put controls in place. We also very much want to protect the blue zone as much as possible to keep the patients in the blue zone safe and the healthcare workers safe from infection. Now, within each zone, we have set up a number of stations that need to be set up at each facility, which creates an appropriate patient pathway through the facility. And I'm going to take you through these in a great amount of detail. I'm going to focus, just to be clear, on primary care facilities first, and then we'll, near the end, we'll stop at hospital facilities briefly before we conclude. So this is a diagram that really shows, and I'll keep coming back to this diagram, of how we patients enter through the yellow zone, through the gate entry, through sanitation, and then through determining whether they've got COVID symptoms or not. For those with COVID symptoms, they then immediately get triaged into the orange zone, or if they do not have COVID symptoms, but could be asymptomatic, they get sent into the blue zone, and we'll talk through this in more detail. Okay, so the yellow zone, every single person that comes into our facility has to pass through the stations of the yellow zone. So all patients will be passing through your 3 primary stations. The first station is your single point of entry into your facility premises. So some of our facilities have more than 1 entry, and we need to make sure that the other entries are closed. We're only managing 1 entry into the facility, and that's really closely managed. That entry needs to be managed by a designated official. This could be a security guard or a lay healthcare worker who's ensuring that only 1 by 1 patients are being allowed into the facility. And really, we need a stronger emphasis on queue marshals outside of the facility premises to manage the social distancing, queuing, and determining who's coming in next outside of the facility. Please note that if we clog patients outside the facility, so if patients are getting stressed and they're not observing social distancing outside, if we're making patients wait for too long outside of facilities, then we're really creating an infection risk outside the facility, which we then bring in when we allow those patients into the facility. So by trying to slow things down and minimizing who's coming in over the time doesn't really help, because we're creating much more risk outside, and that creates risk for ourselves inside. It's been very important for us to mark on the ground the queue distance. So not only asking patients to social distance outside, we don't see that working, but very strongly paint lines all along the pavement. In some cases, we've had to paint those lines for 6 blocks to make sure that patients know where they need to stand. And that is then better supported if there's also either queue marshals outside, or if in any of the facilities, the police are willing to help, especially in the early hours of the morning, to make sure that social distancing is observed. Here you can see very nicely how we've painted those lines at Stretford in Orange Farm, and by patients being able to see where they need to stand, it's much easier for them to observe the social distancing required. For every station, we've also created a set of posters that you can set up in your facility, and we will share the link at the end of the presentation that can be used. Here you can see this is the same facility I showed you in the beginning, where there was a lot of clogging outside. Here you can see we have 2 lines. We have one line that you just observed on the left-hand side with all of our acute and chronic adult patients. And then on the right side, all of our mothers, children, and pregnant women queuing to come into this facility. Now, once patients have actually come through that single entrance one at a time, we don't do the sanitation at the gates anymore. We do the sanitation roughly a meter and a half in from the gate so that it can be much better managed and we don't have pushing and shoving to get to the sanitizer and past the sanitizer point. That means you need to allocate a permanent person to do that sanitation. We've seen that being done by security guards or lay healthcare workers. There are 2 options that you can use here. You can either use sanitation spray, which we still have available in the country, and hopefully we will continue to have because it makes it easier. If you don't have sanitation spray, then you can also use a bleach water solution, and we've set out exactly what that concentration should be. That obviously then requires you to have a water container with a bucket underneath it. The sanitation staff member will then turn the tap and the patient holds their hands underneath. So here you can see this is our sanitation station, very clearly marked on the floor where the patient stands. You can see on the floor, we've actually marked also where the sanitizer stands. This poster shows you if we're still using a sanitizer bottle. This poster shows you if we now need to move to water and bleach because we don't have enough sanitizer left anymore. This is very slowly controlled. So you have one person coming from the gate, passing the sanitation station, and then moving on to our 3rd and last yellow zone station, which every facility needs, which is what we call your first screening station. Now, your first screening station is, again, a short distance from your sanitation station. Again, it's outside of your facility buildings. We haven't yet actually passed into any facility building. And this is usually staffed by lay healthcare workers. If you have enough capacity, you could use a clinician to supervise. But really, this is your first screening. Patients are going to be patients with symptoms that have passed through this screening station will be screened again. This is really what we want here is a very fast flow screening process so that patients are not queuing and getting clogged outside the gate, but moving quite quickly into the facility. We also probably need a queue marshal here to make sure that from the sanitation station, people are lining up appropriately online, social distance apart to get to the screening station. And I'll show you some pictures. And I'll also go through what those screening questions are. What is really important for us to point out is that some of our facilities, especially the community health centers and hospitals, have got 24-hour services running. Now we know that these stations, especially the screening and sanitation stations, may no longer be running after 4 o'clock. And that really means that to still provide the necessary protection, that screening then needs to happen in front of the emergency department or in front of the maternal and obstetric unit after hours before patients are then allowed into the emergency departments. And we'll talk a little bit more about emergency departments and the need to isolate. So here's a picture of Chiwelo CHC, one of the facilities that have been set up. And you can see these are the first screeners. Every patient has to go past a first screener where they then get divided into those patients with symptoms or without symptoms. You can use a chair and table setup or In quite a few of our facilities, we're only using a chair with a cross where the patient needs to stand, and a clipboard with a symptom screen, as well as the stat sheet, because most of our facilities are keeping stats of how many patients they're screening. This is the setup in Orange Farm. We've got 5 screeners across the two roads as you come in. And they're the patient standing with the screen in front of them, appropriately attired in PPE. I'm not going to discuss the PPE requirements per zone in detail. They are in the guide, which I will share the link with you at the end, so that you could understand the PPE requirements per zone. This is Alex, where they've got a gazebo over the screeners, and all the patients are passing their 3 screeners. Now, the questions which we're asking, we really at this point want to keep very simple at the first screening station. We don't want to be taking temperatures or SATs or anything else really that will lengthen the time taken for the screen, because we want it to be fast flowing. So at the moment, the screening questions are: have you developed a cough or fever or shortness of breath, or have a sore throat in the last 2 weeks? Also, for many of our patients, especially in South Africa, because of TB, they've had a long chronic cough, and that should still screen them positive if that chronic cough has got significantly worse in the last 14 days. And then similarly, if a patient has suddenly lost their sense of taste or smell. So for all patients coming into facilities, we want to ask these screening questions without taking a temperature, without taking a SATs, or without asking any more detailed HIV or TB related questions. That will all be moved to the next station, where they will be managed by a clinician. Patients then that screen positive to any one of these questions, so either a cough or a fever or shortness of breath or sore throat or significant worsening of a chronic cough, or they've lost their sense of taste or smell, will then be screened positive and will be directed to the orange zone in the facility. They will not go into the blue zone for any purpose during their visit. For patients who screen no to all of the screening questions, they will then screen negative, and they will be directed into the blue part of the facility. So just to emphasize that again, if you screen positive to any one symptom, you're directed into the orange zone, the high risk zone within the facility, or without symptoms, blue zone, although we still recognize that you can be asymptomatic, and so we have to set up our blue zone appropriately. This really means that a lot of our setup investment is going to be in the orange zone, because those are often now external to the facility buildings, and we need extra equipment and setup. The blue zone is your existing facility buildings and services with some setup, which we'll talk about, but really allows you to leverage and continue to use your existing services for all your patients that have screened blue. Okay, then what we also do throughout the setting up of the facility is marking on the ground very clear pathways between the stations. So where we're moving through from one yellow station to another, they're very clear arrows on the ground showing the patients what direction to go, so we don't have patients getting lost. Okay, so I'm going to now move on to the orange zone. These are all our high risk patients, our patients that have screened positive for COVID symptoms, and go through what we do for them. The first station within the orange section is what we call now the second screening and management station, or what we used to call in Joburg the temporary chest clinic. Many of our facilities are still calling it that, which is fine. The best option for the screening and management station in the orange zone is an external tent that can be clearly seen from the first screening station. But you can also use you can use a row of gazebos, you can use a cordoned off area outside under cover, or if you have, which we have seen in some facilities, especially the hospitals, a separate building or piece of the facility that's not being utilized, or that can be closed off from the rest of the facility, that can then be turned into your orange screening and management station. So here we've just set up from the best option, which would be a fixed tent, so really a strong weather resistant tent outside of your health facility buildings, to using a separate building if you have that one. We've seen that with some of the MMC, the medical male circumcision spaces that are not being utilized during COVID that could be utilized for this. Alternatively, I've seen a primary care clinic where they've got a separate little wing of their clinic which they could cut off from the rest of the facility, or a row of gazebos, or they're still adequate, but perhaps the most difficult in bad weather is just a cordoned off area. So here's a picture showing you what we've done at Stretford. We're using a row of gazebos, so we joined 3 gazebos together to create our orange station. And we've set up our chairs 1.5 meters apart. You can see that it's been painted on the floor where the patients sit. And then we've screened off in front a cubicle where the clinician works and sees the patients. So which is the important staffing for the orange zone or for the screening and management station? We need an orange zone clinician, either a professional nurse or doctor. This person will screen, assess, and manage all the patients with COVID symptoms. At the higher volume facilities, you may need 2 clinicians, depending on what your volume of patients are that are coming through. We'll talk a little bit about volume. At the moment, it seemed very manageable in these big CHCs with 1 clinician. We're probably seeing somewhere between 20, 40, maybe 50 patients through this screening zone on a daily basis. Then absolutely vital are what we call runners. We are using either wobots or community health workers. These people are really the patients and the clinician's feet around the blue service, the blue zone. So because the clinician is going to be managing this patient in this external, mostly external tent, and the patient will not be allowed to go into the blue part of the facility, we need to make sure that we can collect, if we need a file, because we need some sort of history from the patient, that file can be collected from the blue zone. Or if the doctor scripts a patient, they can either have the common drugs with them in the orange tent, or they would then send a runner with the script to the pharmacy to collect the treatment. Many of our patients coming in with symptoms are chronic patients who also need their chronic refill. So the runner would go to the chronic services to collect the refill. So really the runners are the people that are able to move instead of the patient moving. They go and they also make sure that the patients remain in their seats, that patients do not move from one seat to another. Very important, the orange zone, that a patient is allocated a chair and they stay on that chair for the entire time they're there. It's only when they move that chair gets disinfected before another patient sits on the chair. So they will welcome the patient, explain to the patient why they're sitting there. They will run for the doctor or the clinician into the blue zone to fetch anything that the patient needs. They will then move with the patient to the testing center to explain what the patient needs to do there. And they will usually navigate the patient out of the orange zone. So really important. The other people that we also use in this orange tent is potentially, if there are additional available staff, as a counselor who will counsel the patients while they're waiting on the need for home isolation. An orange zone cleaner, so there's a permanent cleaner available, can also be shared with a COVID testing station. And then where this facility also needs a head count or temporary folders to be opened for the orange zone patients, because they won't be going into the facility registry, then that administrative clerk will also be based in the orange tent to make sure that the head count is taken appropriately. I've already explained the waiting area being set up where the chairs 1.5 meters apart, and the clinician's consulting area being cordoned off nicely. Cleaning procedures in the orange zone are extremely important, and that's why if there's not a cleaner allocated, the staff present in the orange zone need to do it. So the runner and the clinician cleaning all surfaces at least 3 hourly, but chairs and desks, tables of the clinician need to be disinfected between every single patient. We've also set out what that bleach and water solution looks like. These are just more photos of the same process. Here you can see our clinician in her cubicle, in her appropriate PPE. She can either be in a gazebo attached to your main tent, or she can even be in a room in the facility if that's got an external entrance and can be blocked off from the rest of the facility next to the waiting area tent, or just in a screened off cubicle as we've shown you. I'm now going to go through what that clinician does. So really the 5 steps to screening, assessment, and management of the patients. In quite a bit of detail, but perhaps just to summarize briefly, the clinician's most important first thing to do is assess the severity of the symptoms and the need for emergency department or hospital referral. Then determine the need for COVID-19 testing using the updated PUI criteria. Provide counseling on home isolation and give the patient the information leaflet on this. Ascertain the patient's HIV status to determine TB risk and therefore whether they need an HIV test or also a TB test for collecting sputum. And then determining their reason for clinic attendance and managing that reason, or alternatively calling a specialized clinical service if the generalist in the orange tent can't actually help the patient. We will go through this in a little bit more detail. So to assess the severity of symptoms, we need a temperature taken with an infrared thermometer. We need oxygen sats and pulse taken, ideally with a mobile sats machine. And we'll speak about this a little bit more, I'm sure, in the question and answer section. But we actually see a lot of our patients not reporting shortness of breath, but having silent hypoxia, and actually, if we take their stats, realizing that there's a problem, and then a respiratory rate. Based on what the ranges of those 3 indicators are, we determine who's got severe symptoms. If they have severe symptoms, we really need to provide oxygen if available. So where possible, either in the emergency department in an isolation room, or what some of the facilities have done is set up a gazebo within the orange zone with an examination bed and oxygen available until the patient transport comes to refer that patient to the hospital. We don't continue the screening process for this patient, but really want to get them to hospital as soon as possible. If they have mild or moderate symptoms, then we will manage them in the orange tent. Okay, this I've explained. Severe, they go off to the emergency department or to the hospital. The second step is to determine whether this patient, this is really verifying the screening that the first screener did. So they are then checking whether this patient actually needs to go for COVID testing within the orange zone. And from 2 April, the PUI criteria was pretty much everybody that's got either a cough, a fever, shortness of breath, or sore throat in the last 14 days. So 90% of your patients that are coming through the orange zone need a COVID test. It's only if they were, for some reason, not the appropriate people to come through, or if we screen them positive because of loss of sense of taste and smell, and that we expect for it to come into the PUI definition in the next week or 2. So those patients will also be tested. Once we've determined who needs a COVID test, if they screen positive, they will go for COVID testing and then home isolation. So we need to educate that patient about the testing procedure, how they'll get their results, and the immediate requirement to isolate. And we provide them with this patient information leaflet that explains isolation. They can read it in more detail. If they screen negative, we'll explain to them that they need to isolate. They still need to isolate for 14 days, provided that's appropriate, and that's the clinician's discretion, and provide them with the information leaflet. Thereafter, we need to ascertain their HIV status. So either they are known positive, whether they're on treatment or not, and here we set out what treatment to provide, but also if they're known positive, we do want to make sure that we complete the NHLS form for TB and send them for a TB sputum so that we can do a gene expert for them. If they're HIV negative, if they've tested negative in the last 12 months and you're not particularly worried about the HIV risk, then they don't need to have a gene expert done unless they're known TB contact. If they haven't tested, we need to be able to provide them with testing. And that means we need testing available, and we'll talk about that. There needs to be testing available in the orange zone. In very low volume facilities, that testing can be done by the clinician. But in most of our facilities, we need to set up an HIV testing gazebo staffed by an HIV tester who can then do that test, inform the clinician of the results so that the clinician can then make a decision of whether that patient also needs a TB test. Okay, So then the fifth step, as we've said, is determine why the patients come to the facility. This is the clinician's ability to be able to tell whether this is something that needs to immediately be dealt with, or whether it's something that can be postponed for return in 14 days when the patient's no longer symptomatic. Obviously, if the patients come for chronic or ART management, then that doctor would need to script the patient and send the runner for collection for the treatment refill from the blue zone. If the patient's here for acute management, then the doctor would comprehensively manage the patient and send the runner for any collection from the pharmacy of any drugs they prescribed, or potentially they've got it as a common drug in the box with them. And if the patient needs to see a clinician, needs some sort of specialized service, which we see in some of our CHCs for example, a dental emergency or a specialized antenatal visit, then the runner would fetch that clinician to come and see the patient in the orange zone. So we've now dealt with the reason why they came to the facility, and thereafter we would then either send them via the COVID testing, COVID and TB testing station, and then they will exit the facility, or if they don't need COVID or TB testing, then they would exit directly through the orange exit of the facility. So as I've said, we need to set up an HIV testing station in the orange zone, which is really just another gazebo very close to the orange main tent, so that patients can be sent there for an HIV test. This is the one in Stretford. We also set up a specialized clinical services station. This is really just a private cubicle with an examination bed if possible, otherwise a table and 2 chairs in case the specialized clinician has to come and see the patient. So here you can see in Stretford, not very clearly, but the first 3 tents are the orange zone, and at the back, which is on the right-hand side here, you'll see another tent, which is a tent where the clinician can come and see the patient if they need to be seen by someone other than the main clinician in the tent. Then to take you through the COVID-19 TB test and TB testing station, this needs to be a little bit further back from the orange screening and management station. This is where we're going to be doing the testing. This gets staffed by a testing clinician, which is either a nurse or doctor, who will then take the swabs. And it can, in a very low volume facility, be the same as the orange zone clinician, but that's definitely not the case in our CHCs or our bigger clinics. What we have noted is that the form filling in for taking the test is takes quite a bit of time. That has actually reduced in the last day, but still we have to elicit contacts, or the patient's contacts, to fill in the contact list properly. And so we find really for every tester, ideally you have somewhere between 3 and 4 form completers, because actually taking the test is very quick, but filling in the forms takes quite a long time. And so you need to, that form completion, you don't want to have that happening within your testing tent, but next door in a separate gazebo close by. So let's just show you how we've set that up. Here you can see behind our main orange screening and management station, we have our testing tent. And next to it, we have a gazebo where our form fillers in are sitting and filling in the forms with very clear markings on the ground for where the patient should stand while the community health worker or some of our student volunteers are completing the forms. You'll see here the 3 tents we've set up. Not all facilities are doing it like this. One for the form fillers in, the next one is for donning and doffing PPE, and the very last tent on the left-hand side is for the COVID test or for the sputum production for TB. So the procedure is set out in detail in the guide for testing, but I think most of us know that there's 3 options. The most sensitive is going to be a sputum. So if our patient has got a productive cough, we wouldn't actually take a swab at all. We would request the patient to produce a sputum both for TB and a separate sputum for COVID testing. If they don't have a productive cough, then we either do a nasopharyngeal swab or oropharyngeal swab, depending on which swabs we've got available. The thicker swabs being for oropharyngeal, and mostly in Johannesburg, those are the ones that we have available. TB sputum can be taken in the same tent because the ventilation and PPE is the same, or if you've got a a bigger open space like we do over here further back, then the patient delivers that sputum behind this whole zone and comes with the jar and gives it to the nurse. This is how it's been set up in Alex, where they've got Alex CHC, where they've got a little bit less space. And so it's a little bit closer together, but again, you can see how the patients are waiting for their testing after they've already had their forms completed. Then once the patient has now completed testing, which is the last step before leaving the facility, they will then head out through the orange exit. So let's just talk through this a little bit. Once a patient comes in through yellow, they'll come in through the yellow entrance. They will not exit through the same entrance that they came into the facility. We need to then set up an exit for orange patients and an exit for blue patients. This isn't always very easy in all of our facilities because they often only have one pedestrian gate and a gate with sort of a boom gate for cars to come in. And that means then very sort of clever splitting off which side of the boom gate is the orange exit. Potentially the pedestrian gate is the blue exit with the orange patients coming in through the middle. So we can talk a little bit through this, but you really need to make sure that you don't have patients crossing pathways. And once they've come from orange, that they exit through their own exit and leave the facility. What I did miss out saying is that all of our patients, all of our symptomatic patients coming into orange do need to be masked. Most patients now over the last 2 or 3 weeks are actually coming in with homemade cloth masks. So that's good enough. If they don't come in with a cloth mask, we either need to provide them with a cloth mask or with a surgical mask for the entire period that they're in the orange section. The orange section needs very clear arrows marking the exit because it's not always clear to patients, and often it's useful to get the runners to help the patients navigate out of the facility. So here you can see in this diagram, 4 is our big orange tent, 7 is our testing tent. So we either go straight from our orange tent to our testing tent and out, or if we're severely unwell, we may go to the emergency department or to patient transport to take us to the hospital, for the patient to be taken to the hospital. So moving on to the last section, which covers the blue zone. So the blue zone are all the patients that have screened negative are now going to be managed within our routine health services, within our routine buildings in the facility. They may, however, be asymptomatic, and so they may still pose an infection risk, and this is really important. And so we still have to put quite a lot of IPC controls into place in our blue zone, with all of our queues and waiting areas marked clearly on the ground or on the seat so that we don't have patients sitting or standing close to each other. We also need proper adherence to cleaning protocols. Ideally, we really want the blue zone cleaned three hourly, but at least twice a day, and that once patients come into the blue zone, that they exit through the blue exit. I'm going to show you a few photographs just to illustrate this, but it does mean that all of these stations, registries, vitals, outpatients, antenatal, family planning, mother and child services, chronic care services, HIV testing services, TB services, all of these services need to make sure that their chairs are marked so that patients know where to sit, their lines on the floor if patients are made to stand, and that there's very clear arrows directing the patient from registry to the service and then out through the blue exit. Okay. Let me just show you some pictures first. Okay, so here you can see this is registry in one of the clinics. So we've physically blocked off every second chair so that patients cannot sit next to each other. Here you can see the OPD, where it's been made very clear on the benches how many patients can sit and where they need to sit on those benches. You can see by doing this that patients have very nicely adhered to those seating arrangements, but this does also require some active monitoring by the clinicians and staff working in this area so that the patients comply while they're visiting the facility. Just go back here. Within the blue service, we want to, wherever possible, reduce the number of service points that patients need to visit. So we're not extending their time in the facility. We want to reduce the amount of time spent at the facility wherever that's possible. We want all places marked for social distancing, and we want to ensure that the queue marshals and all staff working in the area are working towards making sure patients are complying with social distancing requirements. We've also seen some of our facilities have externalized their chronic treatments or their art refill. This is one of the facilities where they've set a gazebo up outside of the facility in the blue side of the facility. The patients are then brought in from the outside queue, and they actually wait within this fenced off area, which you can see at the back, for collecting their drugs from the primary healthcare team and then exiting. So these patients actually are not going into the facility at all. They're collecting their refills outside. And so that means that all orange patients are kept out of the facility buildings, and all the chronic treatment patients are also kept out of the facility buildings, therefore lightening the load within the facility. The only issue obviously is how long this is sustainable, because it's a lot of work by the primary healthcare team to set up outside like this. And so it may not be feasible in the long term. Again, we've said very clearly that your blue patients won't exit through either the yellow entrance or the orange exit, but will exit through their own directed gate to leave the facility. Then lastly, I'm just going to discuss hospitals and the additional 3 components that we have to consider for hospitals. So for hospitals, everything outside will look the same as what we've described for primary healthcare. You need to set up all of those stations outside. Again, your single entry in, your sanitation, your first screening station, your orange zone for your outpatients, and then your blue zone for your, your orange zone for your outpatients with COVID symptoms, your blue zone for your outpatients without COVID symptoms. But then you also need to set up your emergency department, your PUI and COVID wards, and your non-COVID wards appropriately. And so I'll just describe this a little bit using these 3 diagrams. So within your emergency department, this can be both at your community health center or your hospital. You need to identify an isolation room. Now that might be possible within the emergency department. Alternatively, it can be a repurposed room not being used or taken away from some other service. We've seen at one of the clinics where the rehab department has been turned into the isolation emergency department because it's very close to the normal emergency or routine emergency department. Alternatively, if none of those are possible, you could set up an external tent. This would then need your examination beds, it would need your oxygen supply, but this would really, very importantly, keep your symptomatic patients out of your routine emergency department so that they can be managed separately. Again, it depends on whether it's a hospital or a community health center, whether you have separate staff that can manage the isolation part of the emergency department or not. Then in a CHC, you would then refer a patient that was severe to the hospital. In the hospital, you would refer them from your emergency department once you've identified them to be severely symptomatic. They would then need to be admitted into what we call a PUI ward. Now, a PUI ward is while the patient is waiting for their result. So at this point, we don't know whether they're positive or negative for COVID. And so at that time, they have to be kept separate from each other. This means either in separate rooms, or if that's not possible, in a ward where there's very clear separation between the beds, either with actual separation panels, separation screens, alternatively keeping those beds 2 meters apart and making sure patients do not leave their bed, crossing to any other patient's area around their bed. It also means that all toileting and bathrooming facilities need to be provided individually. Patients cannot share bathrooms. This is really a time where commodes and other toileting options can be provided at the bedside, so we make sure that patients are not sharing bathrooming facilities. As soon as that patient result comes in and they're negative, they can then be referred to the negative part of the hospital, to the general ward, or if they're positive, they can then be referred into the COVID ward. Now, the COVID ward is slightly easier to manage than the PUI ward because these patients now all have COVID, and so they can use shared bathrooms, and there can be more patient interaction without as much worry. In the PUI ward, I think it is worth talking very briefly about how important it is that the healthcare workers are very careful here between patients, because we don't want to be transferring virus from one patient to another. In our PUI ward, we've got a mix of negative and positive patients. And so that really means you want to manage the patient completely before you move on to the next patient, because you're going to have to then remove your PPE, at least your gloves and your apron, put new gloves and new apron on before you move to the next bed to manage a different patient. Within the COVID ward, you would then need to change your PPE every time you come in or go out of the COVID ward. So really making sure that within our hospital space, our emergency department has an isolation space. We have a possibility for managing patients separately until we have their test results. And this is really a problem at the moment. We can talk through briefly because the turnaround time is just getting longer and longer. At the moment, we're waiting almost 7 days to get a patient's result. And then lastly, making sure that you've got a COVID ward where our COVID confirmed patients are being managed separately from everybody else. There's also a video here, if you haven't seen it already, the way that Helen Joseph has set itself up following this guidance. It's a 20-minute video that takes you through both the external stations at a hospital, which I've described, and the internal wards, which might just set it out a little bit more clearly for you. So thanks very much to all my contributors and co-authors and the people that have worked very hard in Johannesburg to set up the 6 model community health centers and are supporting some of the district hospitals to get set up. The documents that I've spoken through, this primary care facility preparedness guide, is available at this link. And there's also a short edition that describes the hospital editions for you, and the posters that were on all the slides are also contained in the English and Zulu links below. Over to you, Prof.
Thank you very much, Lynne. Great stuff. I really appreciate a thorough view on it. So let me ask quickly, do you want to just take these questions
Sure.
and we can just go through that quickly?
Sure,
the questions are from Buluze. You can see the question. How can we detect it first, screen the case when we know the majority of cases arriving as sort of asymptomatic? So in other words, you know, considering that there's so much asymptomatic, is there any point in that screening? What is your thought about it?
So at the moment, we know, what we do know is that our higher risk patients for transmission are our symptomatic patients. We are, even in our blue zone, setting up IPC controls with the social distancing, etc. But what we are doing is removing our symptomatic patients, so our coughing patients, from the facility to manage separately, so that we immediately bring down the risk of transmission. Really, and that's why we're doing the screening. It's also why the PUI definition at the moment for who we're testing is based on symptoms.
Okay, thank you. The next question is from Aisha Tabi, who's actually from WHO in Geneva, and she's asking this question. You mentioned that there are 2 lines, one for general consultations and one for mother to child. Perhaps we can talk about those queues. I think Aisha's assuming that the queues are actually a triage of sorts. So she's sort of wondering about whether it's mother and child and not for COVID related. I think you can see the question.
Yeah. So look, all the facilities have taken slightly different approaches to the queues outside. What we do find is that if we try and do too much splitting or screening outside the facility, number one, that's quite difficult, because who's going to be doing that? And that means you have to walk through a fairly uncontrolled environment trying to triage patients. But also we find that the other problem with that is that we start to create competition between the lines outside. So if we have too many lines with various different people in each line, then we start getting people getting frustrated because one line is moving faster than their line, or the next person isn't being taken from a different queue. So we really tried to limit as much as possible the queues outside. We initially recommended only a single queue, with patients then obviously only being split as they came in. And most of our facilities have preferred to split the antenatal mother and child EPI patients on one side. This is not because of vulnerability or any other reason, but because that part of the facility is located together. And so the people from that part of the facility are saying, okay, now we can take the next 5 for EPI, we can take the next 10 antenatal visits. And so it's more of a management process in the blue zone if that queue is separate. But we have also seen some facilities that are asking patients to triage further outside into acute and chronic queues, or one acute, one chronic, and then antenatal and MCH. We're not triaging patients outside based on symptoms at this point for a number of reasons. We think it creates stigma. We're not sure exactly how well it's adhered to, because what we also worry about is if that queue is particularly shorter, that people might just join it. And so we veered away from asking patients to queue themselves based on symptoms.
In fact, I think just to make it clear to Aisha, there's no triaging outside based on COVID symptoms. So no. You must understand them. And I think that that question of how do we separate out the queues in Itireling, for example, they just put up, the person standing in front of each queue, chronic, acute, and mother and child. And so they just separate themselves out, but they're all going into the facility and going to the same triage system that will ask the COVID questions, and then they become blue and orange. And if there happen to be a family planning acute and chronic having symptoms, even though they came for their other reasons, then they got COVID symptoms, they're landing in the orange. If they don't, they go into the blue. So I think just to be clear about the triaging is not happening outside, but in the queued side. So
no, the only triaging is based on what service they came for. Mm-hmm.
Yeah, and we try, I think it can be done simply. You don't want to have any complicated stuff, and you don't want to have this competition, because it starts crowding up at the front, because people somehow think they can jump the queue and move faster, and it creates a lot of challenges. So in Shawelo, it doesn't work very well. In Itireling, it works well. So I think it can also depend on staff and the way in which they manage it outside. But that outside problem is an enormously difficult problem to deal with. In Joburg, we've in fact turned around and said, can we not get the Joburg roads agency to help us with the marks on the ground, because they're not very well done by us as volunteers. But in addition to that, we're asking whether the South African Police Service come in and spend time at the facility between 5 o'clock in the morning and 9 o'clock, when people tend to crowd to come into the facility and get annoyed with the long queues. So we've asked for that as well. So we hope that this can all together become a useful way of managing that crowd outside.
Agreed.
So let's go to Raphael's question. I think for those who can't see, it's, I'm not sure that Raphael misunderstood the questions. Is it enough perhaps to not, I think he's asking about other symptoms. So perhaps Lynne, you can... Yeah, go ahead with
so you can be asymptomatic. You can be asymptomatic just with a loss of your sense of taste and smell, and you will screen positive and be managed in orange. That's coming from the data in the US and South Korea. That's a high proportion of patients, of asymptomatic patients, could be identified by this loss of taste and smell. It's not something that we see in any other patients, really. We're not talking about when you've got a cold and you've got a stuffy nose and you can't smell as well as possible as you used to be able to. We're talking about someone who has a lemon put in front of their nose and actually cannot smell it. It's a very good indication. And so we want to be triaging those patients into orange and not managing them in the blue zone. At the moment, South Africa is reviewing the PUI definition, and it's very likely that in the next week or two that will be included as testing criteria.
Good. Dr. Pinkwane asked a question. I'm just trying to understand it. It's with regard to healthcare personnel who come in and out more than once a day. How often should we screen them? I think, if they go out for lunch and come back, screening. I think this is not about screening a person who's coming in and out, but maybe, Lynn, you can respond to that.
Sure. So this is an important question, how often our healthcare workers are screening and whether they're doing self-screening or whether we're actually sending them past the screening station too. At the moment in Johannesburg, we're asking healthcare workers to self-screen. We are, however, considering whether we should set up a screening station on arrival at work. We don't want it to be the same screening station as patients because we don't want it to be holding up the patient flow. But we are considering whether a separate screening station should be set up for healthcare workers on arrival at work, whether that should be for our more lay, lower level staff, and our professional staff are self-screening on a daily basis. And we're also encouraging staff not to go in and out during work hours. Similarly, in our zones, we're encouraging staff for their shift as much as possible not to move between zones. Because as soon as we move from the orange and yellow zone into the blue zone, then we need to make sure that we are hand sanitizing, definitely removing our gloves, making sure that our mask is either attached to, put outside in the sun while we're having our lunch, etc., and then has to be re-put on afterwards. Ideally, in a perfect world where we had a lot of PPE, where we would be putting on a new mask when we entered yellow and orange. That's not possible because of the supply system. So we need to preserve those for the entire shift. And so that's why we don't really want staff moving in and out of zones or in and out of the facility during a shift.
Thank you, Lynn. I think that, one other thing that I find quite challenging in the facility is that there are a lot of touch surfaces. When we were looking in Johannesburg, we found that, at the clocks, there are these screens and computers. People are sitting behind computers. Patients have to lean on the surface, on a sort of counter and to hear. And these, patients are coming and touching it again and again. This is a way to transfer virus. So I think there's a lot of touch surfaces. You must actually look at railings and doors and gates and just remove all of that as much as you can.
Yeah, that's right. And even, even really trying to make sure that demarcation or marking on the ground is throughout the blue zone, in registry, at vitals. I mean, something we've often observed in vitals is that infection control is not appropriate in the vital station. So we need to make sure that the vitals equipment, especially the BP cuff, is disinfected between each patient, that if the patient's putting their arm on a table while their BP is being taken, that table is disinfected between patients. So that means the staff that are taking vitals need to have a disinfectant container with them at the vital station and some disposable towels so that they can wipe the vitals equipment as well as anywhere where the patient's touched between patients.
Yeah. And I think that another challenge we had today when we went to Mofolo was the question of patients coming into a clerk area and then shuffling from on the bench from one to another. And the matron was completely, how can we deal with this? Patients, are there. We suggested, just take, something that you can wash. It might be bottle caps, and write numbers 1 to 100 or 100 to 200, and just give it to the patient and tell them, now go sit there and don't move. The clerk will call you. And so you're not shuffling around through the entire, the set of benches, because you're spreading the virus all over. So that's another way to manage. I think the fact that you don't want people moving around. The other thing that we are thinking of looking at with our partners is the question of getting appointments much more happening, where we reduce this rush in the morning and making people book appointments come later in the day. Because we need to put up tents and things like that, not because there isn't enough space actually to manage the volume of patients for the whole day. It's because all of them come in the morning. And that is something that's an artificial problem. And so if we can make demand, stretch demand over the entire day, then we don't need all these extra spaces outside facilities. And it's a culture that we need to shift and change. So that's, I think, another very useful point. We also
and especially,
have
I would say that's probably even more relevant for our antenatal and MCH patients, because my observation is that those are really the queues that are staying the longest, because they've got limited capacity within those services to manage. You know, there's a lot that they need to do for those patients, so that it's not a quick turnaround time. And it would really help if that group was split, that only 60% were coming in the morning and 40% were coming in the afternoon.
And it can be stretched. I think Aisha made a comment in the chat group that, you know, doesn't this bring more people to screen for TB? Lynn? Aren't we getting a lot more TB popping up?
Yeah, so we are getting a lot more TB, and that's why we've made it very clear that the orange zone needs to prioritize TB testing. I mean, at the moment in South Africa, at least, and I think in most of the sub-Saharan context, the patients that are coming in with a cough are much more likely to have TB than they are to have COVID at this point. I mean, that's likely to change. So it's very important, and that's why in the clinical algorithm, we've made it very clear that if it's if patients have come in with a cough and they're displaying TB symptoms, that we are assessing them and deciding whether we also need to do a TB test. In the facilities I'm working in, we're probably testing 50% of the patients that are coming into the orange zone for TB. And we're doing that in the same service as COVID. The only difference with the service is that once we've taken the TB sample or the TB specimen, the runner then takes it to the TB department within the facility, and they then manage it. So they register it and send it to the lab in the normal course of how they would manage a TB investigation, while the COVID samples are being managed by the orange zone and ensuring that the courier collects them and they submit it to the lab, and then following up their test results.
So thank you very much, Lynn. This has been really great. I think we're on the hour, and I'm really grateful because you managed to keep it short enough for the hour. Thank you. Well,
No problem
at least
at all.
we have now. Thank you. And if you want to stick around, please do. We are basically going to move to another topic. And this is part of our regular meeting, weekly meeting that we have in half an hour of a little bit of debriefing. And we're going to go through a process of having this half an hour with ICAS. A colleague of Navlika Ratanji is available and is going to go through it. Perhaps, I'm sorry, we have ICAS on the phone. Sorry. Do you mind just quickly introducing
Good day,
Lynn?
Prof.
Yes, Lynn.
Hi,
Yes.
hi, it's Monica.
Lynn, you mentioned, Monica, sorry.
It's Monica. No, not a problem
Monica.
at all.
Apologies, I asked for that name because I thought, let me introduce you properly, Monica.
Not
Thank you
a
very much,
problem.
Monica. So we're really grateful to you, Monica, on behalf of Joburg Metro, and I hope you can take us through the next half hour. Thank you very much.
Perfect. I'm just going to put something here in the chat. So it's basically just my name and my email address, so that you guys, if you have any questions and we run out of time, you're more than welcome just to send those directly to me. So I'm just adding that to the chat. Okay, so for the next 20 minutes, I'm going to put on a presentation that I've prepared with regards to coping skills when it comes to continuous trauma. I hope that everybody can hear me clearly. So I'm just going to try and put this presentation on the screen. Just give me a second.
Can hear you great, thank you.
Perfect, thank you for confirming. Okay. Can everybody see my screen?
Yes, great, thank you.
Okay, perfect. Okay, so I'm going to start. So basically, when it comes to continuous trauma, so just to give you an idea of what continuous trauma is, it's basically the experience and impact of living in societies of real life and ongoing danger. So how is this applicable to you guys as healthcare workers? Basically, with regards to the trauma related to our COVID-19 and the risks and exposures related to this specific pandemic that we are currently facing. Okay, so I do apologize. I just introduce myself as Monica, but that you guys just know I'm one of the specialist trauma team members here at ICAS. So I've been dealing with trauma with regards to group, family, and individual interventions for the last 5 years. Okay, continuing from this slide. So how to manage trauma symptoms. So basically there's a lot of different coping techniques, but the ones that we are going to focus on today will mainly be meaningfulness, connection, strengths, hope, and grounding techniques. Okay. So examples of trauma symptoms. So some of you might have experienced this. It can be on an on and off basis, on a continuous basis. Working in a healthcare sector, we do realize that continuous trauma is exposure with regards to trauma on a daily basis, being exposed to patients, all kinds of illnesses, and even if you work in the ICU, the things that you might see there and how it can affect your mental state. So with regard to the symptoms that you might have experienced before, some of you might be able to relate. For you, some of it might be all new, but some of the symptoms include shock, denial or disbelief, confusion, difficulty to concentrate, anger, irritability, mood swings, your anxiety and fear, guilt, shame, self-blame, withdrawing from others, immense sadness, hopelessness, feelings of disconnect or numbness, even sleeplessness is something that I haven't added here, insomnia, which you guys might be able to relate to. Okay. So if there's anybody that has a question, please just let me know. You're more than welcome to stop me, but I am going to provide an opportunity for questions and answers afterwards as well. Okay, I'm going to try and stick to the 20 minutes to half an hour that we still have to our availability. So one of the first coping techniques that we as trauma counselors make use of to assist our clients is to help them understand the term meaningfulness and to apply that to their lives. So basically meaningfulness, as I've summarized here, is through meaning making, the experience isn't as random, chaotic event, but one that has meaning for you as an individual. So it's basically to try and find the understanding with regards to the difficult situation that you are experiencing, your challenges or the specific trauma. And the other thing is when it comes to meaning making, directly slows the development of your PTSD symptoms and as well as depression and facilitating your effective coping mechanisms. So usually when it comes to our clients, when we try and create meaningfulness or understanding with regards to a difficult situation that they might find themselves in, we usually ask them the question, what have you learned from this experience? So this is obviously something that you guys can ask yourself as well to try and create meaning or understanding with regards to the situations that you find yourself in, sometimes that can be very traumatic or painful. So just as an example of feedback that we have received from our clients, just to give you an idea of what meaningfulness looks like. So if you'd ask yourself, what have I learned from this experience so far? The examples can be that I've come to the realization that life is short. Due to life being short, I understand that I need to prioritize my life a little bit better, to make amends even. So you've come to the realization that there's a lot of death tolls, and this has brought you to the realization that if this was my last day on earth, would I be happy with the way that I'm leaving it, relationship-wise, what are my achievements, all things like that. Is my family sorted? And then obviously, as an example from clients that I've been working with, had been exposed to COVID already and had fully recovered, just to say that they felt like they deserved a second chance at life and how they're going to embrace it going forward. And then a simple thing as everything happens for a reason. So obviously these are just examples, and the meaningfulness or understanding that you create from a difficult or traumatic or painful situation will all depend on you as an individual, what you need to cope and what you need to try and understand from the situation in order to move forward. Okay, so we're just going to go over to the next slide. So then we also encourage connection. So as individuals, we've been created to connect with people. We've not been put together by biology to actually be isolated. So, which is very difficult considering the time that we're currently in, and that's why we see that people are really struggling to manage the lockdown. So just to give an idea of what connection is, I've added here, as human beings, we find life through complex social relationships and connection to one another, building communities of various kinds that enable us to adapt to changing threats and opportunities. Okay, and then also connection protects us against a number of post-trauma symptoms, just as meaningfulness does, that we discussed in the previous slide, and it by increasing your psychological health and resilience. Okay, so various ways that we can connect, but the main way that we mostly connect is through people and relationships. So it's through family, friends, and colleagues. You can find connection through your environment, through nature, and a lot of people actually do find connection through exercising and going to the gym, which once again makes it very difficult considering the circumstances that we are in. But at least with regards to the technology that we have to our availability today, it enables us to still form a sense of connection. So whether you're going to use WhatsApp or Zoom like we are currently doing, or whatever online platform, it's very important to use that to connect with your family, friends, and colleagues. Even nature, I've heard over the radio today just how amazing it is with this lockdown, how the air is being purified because there's less traffic on the roads. So it's obviously cleaner and clearer, and the skies are more blue, and the birds are singing, and the change in seasons, all these things can actually connect you to nature to give you a sense of purpose as well. Okay, so that's connection in a nutshell. So the third coping mechanism that we're going to look at is strengths, or agency is the fancy word. So basically, expression of agency, or as I've indicated there, your strengths, allows you as an individual to take responsibility for your life. So unfortunately, a lot of times things happen in life that are unfair, and you don't always understand it, and you can't control it. But one of the things that you can control is your attitude and what you're going to do about the situation and your mental health state going forward. So how we usually generate strength with regards to, or identifying strength within our clients, is to ask the two following questions. So how have you faced and overcome challenges in the past, which I am sure that a lot of you have been facing in the past. A simple example of that is a lot of us have lost patients a lot in the healthcare sector, as well as perhaps a family. So bereavement is a common challenge that everybody has to go through in life. And then you get other kind of traumatic situations as the COVID-19 risks that we are currently facing, and living in the context of South Africa, just looking at the crime rate, that in itself is a challenge for a lot of people, with whether you've been directly affected or know somebody that had been affected by crime in the past. So this is a very nice question to ask, to see how you have overcome these challenges in the past, and then to ask, like, what have you done to cope, and was it helpful? So obviously just to identify the strengths and what you've done, and whether it was actually helpful, because obviously it's not going to help if you've actually submitted to alcohol abuse, because obviously that's a coping mechanism, but it's a negative one because it's not going to be effective and helpful moving forward. So we want to try and find the healthy coping mechanisms, which every individual has within them. So sometimes we just need to facilitate that during a session. So examples of helping of healthy coping mechanisms with regards to strength-related coping mechanisms are the following. So some of it could include talking about it. So this seems so, how can I say it, so simple, just talking about your feelings or talking about the experience, but there's so much power in actually expressing what you've been going through and the difficulties. I usually tell my clients, if you view yourself as a dustbin, we all have some kind of garbage in our life. So the difficult situations and challenges and traumas that you've been going through in life, you are the dustbin, and that challenges are the garbage. And as you fill the dustbin with everything that you've been confronted with in life that had been painful or hurtful, and you don't deal with it, the dustbin is eventually going to overflow. So just talking about it already makes space for dealing with some of that challenges that you have been experiencing. So it just lessens the load so that you don't come to a point where the dustbin actually overflows, which I'm referring to you as the individual, and you start to get into a position where you are burnt out or you are at risk for depression or whatever the case might be. So talking is very helpful, and especially positive self-talk. So the power of the mind is amazing. So if you can really just replace some of that self-talk with positive ideas around yourself, positive ideas around the world, is already going to help you to move forward from any difficult situation. Then obviously, like we said, support from others, connection is also seen as a strength. Some people like to diarize and just write. So instead of talking perhaps to somebody, just writing it down and using your pen and paper just to get out those feelings and thoughts already helps you to move forward as well. And obviously professional help, which is very necessary, especially if trauma symptoms persist after 4 to 6 weeks. So we usually give it a leeway of 4 to 6 weeks. And if you don't see any change in your behavior, then obviously we need to intervene a little bit more to try and sort out underlying issues. Not trying to stay the victim, obviously, so otherwise you're not going to feel empowered and you won't be able to move forward because you're going to be stuck in one certain place. So we always try and encourage the client to try and be the victim. So in any difficult situation, how are you going to be the victim and the hero in all of this? Okay, and for me, just being an essential worker in itself is telling me that you are not the victim, but you are empowering individuals to enable them to have a wonderful, healthy life going forward. So that in itself should actually be a strength for you, just to know that you, in this difficult situation, is already a little bit of a light in the world. Okay, and then obviously finding strength through your spirituality. So I found like a lot of our clients actually find strength through their spirituality, whether it's going to church or praying or using meditation as a form of coping. This is something that has helped a lot of people through difficult situations. So this is one thing that we really try and encourage when it comes to finding your strengths, and then obviously broadening your knowledge to read up on trauma and trauma symptoms. So a session like this in itself is broadening your knowledge just to have a better understanding of what you're going through. Why are you experiencing this? Okay, wonderful. I'm not crazy. Everything that I am seeing and understanding is valid. Okay, so, and then obviously after identifying, oh, I do apologize. Just quickly want to go back to that specific slide. So how do we, after identifying your strengths, how do you apply it? It's by setting goals for yourself and by focusing on the strengths and what you've learned from others. So that's why debriefing sessions are also very important, because it gives you a learning experience with other people within the group. So maybe it might be that you haven't gone through a specific trauma yet, but somebody else within the group actually did, and they can tell you what they found very helpful. So that's why it's also very important with regards to finding your strength to talk to people that might have gone through something similar and what they've done to help them to get through it. Okay. And then, like I said, empowering yourself with resources to move forward. So that's part of getting the knowledge, and then obviously the resources are facilities where you can go to find professional help or whatever the case might be. Okay, so going to the next slide. So hope is also, so we've done meaningfulness, connection, strength, and now we're with hope as a coping mechanism. So hope is not optimism or wishful thinking. It's about imagining a different, healthier future, finding the energy to do something to try and bring that future into being. It's thinking and acting forward. If we can see a positive future, this nurtures the life force to enable it to happen. So once again, hope is not wishful thinking. So it's that perfect cliche of time heals everything. And that's what hope is about, like to take people's testimonies to know that they've gone through difficult situation, but look at them now. They are able to conquer this. So obviously, having experienced a difficult challenge in your life, whether it's a trauma or another type of hurtful situation, a relationship that didn't work out, you are able to move forward from that in a healthy manner, because a lot of people have done it before you, and therefore that enables you to also do that. So you just need to keep on to that, and especially looking at the current circumstances that our the whole world finds itself in with this COVID-19 virus going on. There had been viruses previously 100 years ago or even before that. I don't know all the history, so I don't want to say something and it's incorrect, but I know that we have managed to survive as individuals from that. So we've had that before, we can learn from that. The technology is better, so we can recover more quickly than we have done in the past. So that's something to be hopeful for in the future. So another thing that's wonderful about hope is it can also positively impact on your physical health, mortality rates, aging, resilience, problem solving, adjusting to change, reduce absenteeism at work, and also increase your productivity. So if you have a hopeful mind, it's the same as having positive self-talk. Okay, and then the last thing that I just wanted you guys to take note of is grounding techniques. So grounding techniques is a technique or a coping mechanism that you will use in an instance when you are experiencing a trauma symptom. So grounding techniques help you to reconnect with the present and bring you back out of a panic attack, flashbacks, unwanted memories, distressing emotions, or disassociation, to help you separate you from the distress of your emotional state or situation. So this is mainly done by stimulating your 5 senses. Okay, so the different senses that we have needs to be stimulated. Obviously, it's not always possible to stimulate all 5 at once, but some of the ways that you can do it. So say now you are having a panic attack or you are having an unwanted memory or flashback. By squeezing a stress ball usually helps you just to ground yourself, because you feel the stress ball, you move the stress ball. If you can even spray something on the stress ball, you will smell the stress ball, you'll see the stress ball. If you really want to put it in your mouth, which I won't recommend, you can even taste the stress ball. So these are the ways that you can ground yourself if you are already in a difficult situation with regard to a trauma symptom that's acting out at that moment. Even to pick up any or touch items near you. If you're at your desk, just to pick up a pen, just to move the pen around in your hands. If you're close to water, just to touch on water, savor food or drink, so obviously to stimulate the taste buds and the smell. The meditation guides that you guys have already been receiving with regards to breathing techniques is also actually a form of grounding. So any type of breathing exercises also helps you to take a short walk, hold a piece of ice even in your hand, so that you not only see see the ice, but you feel the coldness of it in your hand, a smell of a scent, any kind of scent, maybe to just spray your favorite perfume or a mother's perfume or whatever, a safe space that's going to remind you of where you've always felt safe, and just to move your body. So these are just little forms of grounding techniques, but if you search Google, you'll find a numerous amount of different grounding techniques that you can make use of to help you cope. Okay, so basically there's a lot of things that you can do to help you cope during a difficult situation. So I've only chosen 5 of them that we use due to our time constraints. But I know that we are going to focus a little bit on burnout and self-care next week sometime. So this might also relate to some of the techniques that we've discussed today. But yeah, just to know that you as an individual is unique, and the way that you experience trauma and the way that you're going to react to trauma and the way that you're going to manage trauma might differ from the person next to you. So sometimes you might relate to some of it, and sometimes you might feel that you've never experienced something like this before and nobody else can understand. But whatever you're experiencing, just know that it's valid. So some of these techniques might work for you, some of it might not, but just know that it's a trial and error for yourself as well. So because of your background, your personality, the way you've put together, is all going to determine how best you're going to deal with your specific challenge. Okay, so that's what I have for you guys today. I'm just going to try.
Thank you very much, Monica.
You're more than welcome.
Very, very helpful. I've found it very insightful. I'm sure people are going to ask, can I get a copy of the presentation? So if you don't mind emailing it to me, and then we'll probably post it up together with the video on the post. I think everyone has seen the link I provided on profmusa.com. It'll be there in about a day or two. I think as soon as we get it loaded on, it should be there actually. But we'll hopefully have this available for you. I don't know if there are any other questions and any other comments. I don't see any questions. Nelisa has said thank you for a wonderful presentation.
Okay, oh, wonderful. So, I'm really glad that you guys benefited from it.
For sure, thank you. I think that, as you say, this is, it's still early days. I think we are all a bit more anxious. But the numbers are expected to grow, and I think that we need to take this this part of it seriously. I think sometimes people easily sort of dismiss this. It's not that important, but our self care is actually quite important, and I think we must maintain this half hour regularly. And we really appreciate very strongly ICAS coming forward to provide us that this presentation. So thank you very much. Please tell your seniors that we really appreciate the ICAS reach out to us.
You're more than welcome. And like I said, you guys have my contact details. So if there's anything else, you're more than welcome to contact me directly as well. Okay.
Good. In future, I would really hope, and I think that this does take a bit of safety. Colleagues feel a little bit intimidated to share their thinking. You can, in terms of the question and answer, choose to sort of make it anonymous. So you don't need to feel stressed. You can just put out on the question and answer that you'd like to ask this anonymously, or make a comment anonymously. So please do that. I think Dr. Omo asked the question, how do you encourage people to just talk about their challenges? Most of them just withdraw. Would you be able to comment on that, Monica?
Yes, I'll try my best. So obviously it is very difficult. It's all about trust. So you obviously have to form a platform of trust first in order for people to feel comfortable to engage with you about what's going on in their lives. So without that foundation, obviously it's going to be a little bit more difficult. So sometimes what we do suggest is an anonymous box. So if people don't feel comfortable sharing what they're going through at the moment with you specifically because of confidentiality issues, we do recommend an anonymous box that they can actually just write what their concerns are, and then maybe it can be addressed in a meeting. I don't know if that helps.
No, for sure. I think generally, I think, getting people to encourage them to trust, that's colleagues, for example, it is about trust. So you being a colleague of another colleague and noticing this, you know, please reach out, but I think build it, as Monica said, on a platform of trust. Don't confront them, but engage them. And I think build up a sense of what they feel, how they think. And before you know it, if you have built up that trust, that they would in fact share with you. And I think you have some of these resources that Monica's referred to as a way in which people might be able to cope with some of the trauma that might come. And I think, as I say, you know, it is going to be an ongoing problem. This is not going away in South Africa and not in Africa. So we need to be prepared, prepare ourselves for the difficulties that we are very likely to face as frontline healthcare workers in primary care. So please, I hope we'll take this seriously. So Monica, thank you very much. Thank you to all the participants who are joining with us. I just want to remind you that we are having a webinar tomorrow afternoon at 4 o'clock. Please go to profmusa.com, have a look there. You'll see the link to the registry. It's actually about primary health care, and it's actually about trying to understand what is happening across Africa in terms of COVID. And we have the opportunity to hear some of our colleagues from other parts of Africa, and particularly from Kenya, as to what they're doing, what is going on. And so I hope you'll join it. There is also a webinar on Sunday. Again, the link is on the profmusa.com website. You can go there and join the webinar on Sunday, which is about 1 p.m. South African time, where you can understand what's the discussion broadly about PHC under UHC, and especially in the light of COVID. As primary health care practitioners, mostly, I think most of us are there, we really need to highlight the difficulty of primary health care being dismissed and everybody's attention focusing on big hospitals, especially with the COVID. And I think we need to point out that we are the real heroes in the COVID crisis. So with that, let me thank you all very much once again. Please be safe, keep safe in the work, and ensure physical distancing, wear the masks, be safe, enjoy your weekend. Thank you once again to Monica. Bye-bye, everyone.
Bye-bye, Prof. Bye. Thank you so much.
Thank you. Bye-bye.